here at the Myeloma 2015 meeting in Boston, Massachusetts. And once again, we've had remarkable progress in myeloma. Over the past decade, we've had really a doubling or tripling of patient survival. In this meeting, again, the progress is absolutely palpable. So we're very proud and happy to share some of this information with you on the Patient Empowerment Network. I'm privileged to be joined today by Dr. Irene Ghobrial from the Dana-Farber Cancer Institute, Dr. Rafael Fonseca from the Mayo Clinic in Scottsdale, Arizona, and Dr. Gareth Morgan from Little Rock, Arkansas. Okay. We'll just have a discussion now about some of the major areas of progress. The first one is in the area of our understanding of myeloma, so-called genomics. And there have been very exciting discussions here around advances in genomics and what it might mean to patients in terms of how we diagnose this disease, how we understand the different subgroups and can try to predict who's going to do better or not, and then again, how we can define new targets. So perhaps, Gareth, you can tell us, what do you think the impact that really has been described here of genomics on practice in myeloma has really been?
There must be nearly 1,500 cases of myeloma that have been sequenced now. So we're really starting to see patterns fall out of it. We always knew about the chromosomal translocations and those groups, but now we can put on top of that mutations that really have prognostic significance. And there are good prognostic mutations and bad prognostic mutations. So you can put all of those together and make a score for a patient and predict really what their outcome's going to be like. And I think the real challenge is to do this precision medicine in the future where you target treatment to one of the mutations.
Very, very exciting indeed. I suspect if we were able to do that more effectively, we'd not only target the myeloma cell, but have fewer side effects as well. And,
Absolutely.
You know, as we understand more about the genes, maybe, Rafael, you can tell us, but as patients, we've always heard about standard risk multiple myeloma and high risk myeloma. And have we learned more about that? Are the genomics helping us in terms of understanding what that really is and how to deal with it?
Well, thank you, Ken. You know, at the end of the day, the only thing that matters is that we translate these things for better treatments, better outcomes for our patients. And I think it's important for them to know that when we say standard risk, we don't minimize the challenge that we're still facing with the disease. It's just that there's added things we're doing for patients with high risk. So for instance, we've learned that how we approach maintenance and the use of proteasome inhibitors in high-risk disease seems to be something that needs to be done to abrogate the effect of some of those markers. We're getting better. So we know some markers that would allow us to predict that a drug is not going to work, but I think this is only a very small part. We need to get way better by understanding how genetics make our treatments much better. Not which ones are not going to work alone, that's the first step. But actually, how can we combine and how can we design treatments or strategies that actually will tackle some of the challenges we have, such as it is with high-risk disease.
And you know, the impact of genomics is really changing not only how we understand myeloma and treat it, but honestly, the biology and the study of the genes has also helped us redefine who in myeloma really needs treatment, and putting it the other way around, who has a myeloma that's been called over the years smoldering multiple myeloma and traditionally has not been receiving treatment. And maybe, Irene, you have a tremendous expertise and interest in this area with a brand new clinic that's completely devoted to trying to help identify smoldering myeloma and make a meaningful impact there for patients. What have we learned at this meeting about smoldering myeloma, and do we understand more about it? And what are the different options that we might think about for meaningful intervention?
Yeah, absolutely, Ken, and thank you for this. So at Dana-Farber, we started recently the Prevention of Progression Clinic, and it's really about patients who have this early asymptomatic disease, the precursor conditions of smoldering and MGUS, and trying to really define who will progress to myeloma and who will not. We heard in this meeting that there are so many markers and good markers that we have to date, the Mayo Clinic criteria, the Spanish criteria, yet these criteria are based mainly on how much tumor burden or how much cancer cells you have in your bone marrow. And I think we need better molecular markers and potentially really working together to define true progressors to myeloma and treating them early to prevent progression and prevent end organ damage, bad disease, and then patients who will not progress, and we don't want to overtreat them. And I think in the future, we will have a panel of genes or mutations that we can say, indeed, this patient will progress and should benefit from individualized therapy or personalized therapy, and another person should not be on therapy.
So I think that's very exciting, and what we're really talking about here is in the era of all the new approaches that we have, the new targeted therapies, the new immune approaches, all exciting in the context of active myeloma. Couldn't they be even more active if we could intervene earlier? And our dream is to someday prevent myeloma from ever causing complications way before they happen. So it's really an exciting time.